session. For those of you who don't know, this is a weekly meeting that we hold. It's hosted by the Gastro Foundation in association with the University of New Mexico Gecko Foundation. And this week we have got pediatrics on the program, and I think we're in for a very good session. So thank you for joining us. Just to remind you that the chat will be open for questions, or you can raise your hand after the talk is done and we can have a discussion. And with that, I think what I want to do next is I want to introduce Prof Voster, who is the head of the Human Metabolomics Unit at the University of Potchefstroom, or the Northwest University, I should say, which is in Potchefstroom. We had a meeting last year in October, in which Dr. Dirksen started taking us through the inborn errors of metabolism that manifest with liver disease. And as you know, this is a huge topic, and we didn't get through the entire thing. I think Marley spoke to us about the small molecules and intoxications, and she also dealt with energy metabolism and energy utilization errors. And today we are very happy to share the last section of that with Prof Voster, which is more about the long molecules or the complex molecule problems. So Chris, thank you very much for agreeing to give us this lecture, and we'll look forward to it.
Thank you, Tim. Let me just share my screen. Okay, just minimize the presenters. Okay. Thank you very much. Marley was actually supposed to give this presentation. Unfortunately, she couldn't make it, but I just want to assure you that she gave me very good instruction on what to do. So I'm sure there will be continuation throughout the session. So, okay, there we go. So let me just minimize some of these things. It's going to make it a bit easier to present. Okay, that should do. Okay, so this is more or less, like Tim has mentioned, Marley covered the small molecules and the intoxication syndromes, as well as energy deficiency. And then what I'm left to do is the complex molecules. Now, these include the lysosomal storage disorders, the peroxisomal disorders, the disorders of bile acid synthesis, and as well as cholesterol metabolism, and then some other disorders as well that we will touch on. For this particular session, I'm going to focus on the lysosomal storage disorders. Each of these is actually a presentation on its own. And for various reasons, as you'll see as we go along, I think it's appropriate that we discuss the lysosomal storage disorders at this stage. So just a reminder that there are certain clinical features that could alert us to the possibility of an inherited metabolic disease. What's very, very important, particularly with those with hepatic presentation, is the initial presentation. We very much would like to know whether it's hepatic, cholestatic, cirrhotic, etc. Then the disease course, if it's fluctuating, progressive, there's particular triggers. If there are other systems involved, particularly the neurological system, any unusual or characteristic findings, like, for example, a cholestatic jaundice with a low gamma GT. What is also quite important is a thorough investigation of the liver, the size, the consistency, the edge, all the things that one is traditionally taught is very important. And then, of course, the presence of splenomegaly. Obviously, we want to distinguish this from the secondary causes of hepatosplenomegaly, so cardiac and respiratory assessment may be important. Then the liver function test, or the liver function test profile, like I already mentioned, is very important for further classification of the patient. Patients that respond poorly to treatment, and then if one notices a particular inheritance pattern. And I must say, in general, we struggle to work up the patients with an inherited metabolic disease with an hepatic presentation. So I think the more clinical information we can get, the better the chance of making a diagnosis. So traditionally, this is how we classify the IEMs with an hepatic presentation. In fact, this is how we classify most IEMs, those with that's either due to a small molecule intoxication or energy deficiency, which you have covered last year. and then the complex molecules. And like I already mentioned, the complex molecules include the peroxisomal disorders, the Swinkle lipidosis, which is one of the lysosomal storage disorders. The other lysosomal disorders are the Mikobolysaccharidosis, the oligosaccharidosis, and then the cholesterol storage disorders. Then there are also the cholesterol synthesis disorders, bile acid synthesis disorders, congenital disorders of glycosylation, and then a few other. Now, for this particular session, like I already mentioned, I want to focus on the lysosomal storage disorders. So we will be covering the Swinkle lipidosis, the Mikobolysaccharidosis, the oligosaccharidosis, not in a lot of detail, and then also the cholesterol storage disorders, again, not in a lot of detail. So recently, there a new nosology for IEMs was proposed, and I had a look at the number of IEMs that can present with an hepatic presentation. Now, these are not the disorders; these are the particular groupings of disorders, and there are 52, if I remember correctly, 52 groupings of IEMs that can present with an hepatic presentation. So in a way, it's becoming a bit disheartening. You can study as much as you like. You can't remember all of these disorders. So I think, to have a good approach to a patient that presents with a possible IEM remains very, very important in the workup of these patients. I can perhaps also just mention at this stage is that we've got quite a bit of experience now with patients that were worked up using an extensive genetic approach, either a panel or whole exome sequencing. In some instances, it does give the answer, but in many instances, it doesn't. So unfortunately, I think in the first place, there's absolutely no substitution for good clinical skills. It still remains the cornerstone of making the diagnosis. And then one needs the metabolic testing as well as the genetic testing to get to a final diagnosis. So the ones in blue are the ones that we will be addressing to some extent today. So just my presentation, like I already mentioned, we're going to be talking about the lysosomal storage disorders. We're going to touch on the peroxisomal disorders as well as the bile acid synthesis disorders, and then the disorders of the congenital disorders of glycosylation we are going to touch on. And then what I want to get to at the end is, instead of trying to link a particular clinical phenotype to a long differential diagnosis of possible inherited metabolic diseases, I would like to give you an approach to requesting the correct test when you suspect an IEM in a patient with an hepatic presentation. So I hope that is going to assist you going forward. I've been doing the same thing for the neurologist and so on. And so we're really trying to get to a point where we have the appropriate testing when we have a patient with an IEM. And even though this may not give the answer, it will certainly eliminate a number of conditions, and then from there on we can then through discussion perhaps narrow down to a final diagnosis. So this is just a breakdown of the lysosomal storage disorders that presents with hepatosplenomegaly, and then typically other clinical features as well. And we divide these disorders into the accumulating metabolites. So we have the disorders of Swinkle lipid metabolism, the Mikobolysaccharidosis, the oligosaccharidosis, and then the disorders of cholesterol metabolism. And what I would like to just point out is that these disorders that I've highlighted in dark are the ones that we see most frequently. So we certainly see Gaucher, Niemann-Pick AB. Niemann-Pick C, we don't see that frequently because we don't actually have a test for that, but I'm very interested in detecting more of these patients, so we'll discuss that in a little bit of detail. And then GM1 and FABA, we don't see that much because we don't have an appropriate test, but that may change in future. The Mikobolysaccharidosis, we are very, very proficient in working these patients up, and I'll show you our approach, and we can certainly diagnose these patients. The oligosaccharidosis we do with urinary oligosaccharide analysis. It's not a great test. These disorders are very rare, but that's perhaps also a bit dangerous to say that because, we used to have a test for the Mikobolysaccharidosis that wasn't that sensitive, and we didn't diagnose these patients frequently, and whereas now we do diagnose them quite often. So the oligosaccharidosis is still a group for me on which the final verdict is out. But I think at this stage, the urinary oligosaccharide test that we have probably in some instances do not have the sensitivity to pick up these patients. The test that we offer is not that different from what other laboratories in the rest of the world offer. There is a movement now towards more sensitive testing, but it's still fairly early days. And then what I just want to point out at this stage is that, often the examination of other clinical systems may be quite important. So with the Swinkle lipidosis, we certainly, some of these patients do have a neurological presentation. The presence of cytopenias is very, very important. Abnormal lipogram may be helpful. With the Mikobolysaccharidosis, the neurological presentation is sometimes helpful. Many patients have got coarse facial features and then also dysostosis multiplex that I'll go into a little bit of detail, and so on. So the additional clinical systems that may be involved is quite important in getting to a final diagnosis. In terms of the Pathic presentation itself, I just want to point out that with the lysosomal storage disorders, we are generally looking for hepatosplenomegaly. That is a sign of a metabolic storage disease. But in many instances, the diseases do not only present with hepatosplenomegaly. Hepatosplenomegaly should be there, but there may be some other features that may also be helpful. So some have got mostly hepatosplenomegaly. I say mostly because there are always exceptions. Some have hepatosplenomegaly with or without hepatitis and even liver failure. Niemann-Pick AB is a very good example of that. And then we have Niemann-Pick C, who's got hepatosplenomegaly, and then particularly in the neonatal and early infancy period, cholestasis, which is typically transient. So if you can get that clinical history, then that may be quite instrumental in getting to a diagnosis. And then there are, of course, also secondary causes of hepatosplenomegaly, which for this presentation is not that important. One just needs to be aware of that. Okay, so moving on to the individual lysosomal storage diseases. Of course, it's appropriate to first look at Cachet disease. So the disease was described more than 100 years ago now, so there's a long history here. I think what's important is that, of course, it's autosomal recessive disease, but the genetics is quite complicated. There is the involved gene is the GBA gene, but there's also a serogene, and there's also some patients that has a deficiency in the PSAP gene that present that disease known as the Prof C, which mimics Gaucher. So, the genetics can be quite a bit complex. There's also recombination events between the serogene and the GBA, which one need to be aware of. But I think most genetic laboratories have got this fairly well sorted out. So genetic testing is for, I'd say, probably more than 50% of patients fairly straightforward. The involved protein and involved enzyme is known by quite a few names. We usually refer to it as acid beta glucosidase. And this is an enzyme that metabolizes glucosylceramide to ceramide and glucose. And the accumulating glucosylceramide is what is believed to be the causative agent in the pathogenesis and final pathology of the disease. Now, the Swinkle lipid metabolism pathway is becoming quite important, and this is just because in the past, the instrumentation that we had didn't have the sensitivity to actually measure these Swinkle lipids. But progressively now, we are seeing more and more methods coming to the forefront that do actually measure these complex molecules. So while in the past, we mainly used an enzymatic approach followed by genetic confirmation, I do foresee that within the next probably 2 to 3, 4 years, we may move to a primarily metabolite approach. So this will make it similar to the typical aminoacidemias, organic acidurias, and so on, where we'd first do metabolites, then enzymes, and then genetics. So, and really what opens the door for this is that most of these Swinkle lipids are quite lipophilic, which the end result of is that you cannot measure it in serum or in plasma, but because they are non-specific enzymes that deacetylate or dealkylate the Swinkle lipids, we find these lysosphingolipids. Now, this just means that an aliphatic chain was lost, but to get through the biochemistry, what that means is that the compound becomes a lot more water soluble, and this then does make it possible to detect it in whole blood or even in serum. So in the case of Gaucher disease, the accumulating metabolite is glucosylceramide, but what we are measuring is the lyso version of the accumulating metabolite, commonly known as lyso-Gb1 or lyso-GL1, is the way in which we and many other laboratories refer to this. So I just want to point this out that we do have these accumulating metabolites, and I do foresee that in future we're not going to measure GBA activity anymore. We are going to go straight for the metabolite. So the clinical presentation of Gaucher disease, the important things here is the gastrointestinal presentation, the hematological presentation, and then also the bone disease. 90% of these patients will have splenomegaly at the time of diagnosis, and 70% should have hepatomegaly. So, I think one would think that many of our patients would reach us via the pediatric gastroenterologist or the gastroenterologist, which I must say is often not the case. And one of the things that I want to promote in my presentation here is the testing for lysosomal storage disorders, because I think we should actually see more patients coming from the gastroenterologist. Some of them are, of course, coming from the hematologist because of the thrombocytopenia and the anemia. And then I'm yet to see a referral from an orthopedic surgeon, but I suppose that's possible. Later on, the patients may present with interstitial lung disease, and then there are many other symptoms and signs that is also of importance. This is a famous radiological sign that I thought I'll just show you. This is the Erlenmeyer flask deformity. And what you can see here is that the distal femur is quite thickened in comparison to the normal femur. Really, just for interest's sake, but maybe somewhere it may be important for someone to make the diagnosis. Now, Gaucher disease may also present neurologically. Most patients do not. In fact, most patients do. And particularly now when patients are on enzyme replacement therapy, we find more and more that patients present with Parkinsonism, dementia, peripheral neuropathies, and so on. So it's probably a continuum, and there probably aren't really any patients that do not have a neurological presentation in the long term. But of course, we know that the neurological presentation can be very, very severe, and it can be very mild. And this is what I've tried to illustrate here, is depending on the age of presentation, the neurology is either more severe to the top or less severe to the bottom. Most patients that do present neurologically is either the acute neuronopathic form or the chronic neuronopathic form, and then this is the neurological features that they would then typically present with. So like I say, it's a continuum, but we typically divide our patients into either non-neuronopathic, acute neuronopathic, and then chronic neuronopathic. But what I want to point out for this presentation is that hepatosplenomegaly is always present, even in the acute neuronopathic form, not as severe as in the other two, probably because it hasn't had sufficient time to develop, but it's always present. And then the hematological features are also always present. So really, these are the important things to spot in a patient. There is another form that I just want you to be aware of, and that's the perinatal lethal Gaucher disease that presents either even before birth or shortly after with hepatosplenomegaly, pancytopenia, collodon skin, non-immune hydrops fetalis, arthrogryposis, facial dysmorphology, sometimes death in utero, and when you investigate them genetically, then normally it's very complex alleles, and I'll show you an example of this. The diagnosis is fairly straightforward, so you request the 6-plex LSD test from us. I'll get back to that. We test for the acid beta-glucosidase activity in dried blood spots, and if that's positive, we'll follow it up with sequencing of the GBA gene, and then, like I mentioned, we use the lyso-GL1. Could also be used for diagnosis, although at this stage, it's mostly used for monitoring. If you are monitoring a Gaucher patient, you really should be doing the lyso-GL1. The chitotriacidase and CCL18 is just not as good as lyso-GL1, and if that is available, you really should be doing that. why I'm doing this disease first and why it's important is that enzyme replacement therapy has become fairly widely available now. So there are many patients in South Africa and also some in Africa that is currently on enzyme replacement therapy. Sometimes with a bit of a struggle to get them on. Most of the companies do have humanitarian programs that one can apply for. And so it is very important to make the diagnosis because therapy is available, and this would typically, in a very drastic way, changes a patient's outcome. Excuse me. There are also other therapies in the pipeline. Iliglustat is particularly interesting. This is a small molecule that can cross the blood-brain barrier, so it may be important in patients that do have the neuronopathic form. But what's also quite important is that it's not an infusion. It can be taken orally, so that may be of quite a bit of benefit for many of the patients. And there are many other new therapies that's also coming to the forefront. So it's certainly a disease where it's worthwhile to make a diagnosis. So I'd like to show you this case study. This was quite an eye-opener for me. This patient presented at 1 year of age with hypertonia, hepatosplenomegaly, and anemia. And what we received was a blood card that looked like this. And I remember the day when sample reception came to show me the card, and I had one look at it and I said, no, this sample was collected from the drip arm. The spots are too light and we're not going to analyze it. But then the clinician contacted us and kindly requested that we do analyze it because the patient had died. And in fact, what this is this is anemia, severe anemia from Gaucher disease. And as you can see here, the enzyme activity is greatly decreased. The lysogel-1 concentration greatly increased as expected, and then very, very complex genetics involved. And so this is a case of early onset Gaucher disease, and probably we are missing quite a few of these. The important clinical finding here is hepatosplenomegaly and then also the other cytopenias. Okay, so moving on to Niemann-Pick AB or acid sphingomyelinase deficiency. It was discovered some 40 years after Gaucher disease, and supposedly it's quite rare, 1 in 200,000. So if you're to take the birth rate in South Africa, 1 million babies a year, we're looking at around about 5 patients per year. I think it's more common than 1 in 200,000 in South Africa, so probably looking at slightly more. Again, it's autosomal recessive disease, of course. The protein that's involved is acid sphingomyelinase. And in this instance, the accumulating metabolite is sphingomyelin. And very similar to Gaucher, we also classify it into a type A, which is early onset with neurological symptoms, a type B, which has got a variable onset, and then an intermittent type, which has got mild neurological features. Okay, so this is the pathway of sphingolipid metabolism. And of course, we're not going to go into detail of this, but what I want to just point out to you is that there are some very well-known lysosomal storage diseases here. Gaucher, Niemann-Pick AB, Krabbe, which is not of interest to the gastroenterologist, a neurological presentation only, as is metachromatic leukodystrophy, Fabry disease, probably not all of interest to you either, and then GM1 gangliosidosis, GM2, Sandoff, and so on. And previously, we couldn't test for these diseases using a metabolic approach. We had to use an enzyme analysis, whereas now the analytical methodologies that has advanced to this to a stage where we can actually test for derivatives of some of the metabolites in this pathway. And I do foresee in future that we are going to have a metabolic test. And the nice thing in metabolic test is that, it gives you a profile of the pathway, and it enables you to diagnose a lot more than what you can do with single enzyme analysis. In any way, so here is the defect in Gaucher disease, and then here's Niemann-Pick AB, where sphingomyelin cannot be converted to ceramide, and you find this lysosphingomyelin that accumulates, as well as lyso SM509, of which we haven't been characterized all that well. And we can potentially use this to diagnose Niemann-Pick AB in future, as well as many other sphingolipid disorders. So this is just the different presentations of Niemann-Pick AB. So on the one hand, you've got the classic neuronopathic presentation, and on the other hand, you've got the chronic non-neuronopathic presentation. And you can see again, it's very appropriate to the gastroenterologist, vomiting and diarrhea, hepatosplenomegaly. The neurological system is, of course, very important, but the other thing that can be quite helpful is an ophthalmological investigation. Many of these diseases will either have a paralysis of some of the eye muscles, but then also some of the retinal findings, like, for example, a macular cherry red spot can narrow things down quite significantly. Now, the cherry red spot is not pathognomonic for Niemann-Pick AB, but there's certainly a very limited differential diagnosis. Niemann-Pick AB doesn't only cause accumulation of Swinkle lipid, it also causes cholesterol accumulation, and because of this, we can find abnormalities in the lipogram and then also the associated clinical features. So these patients will present very, very early. On the other hand, the chronic patients may present quite a bit later, although hepatosplenomegaly may be present quite early. Again, very appropriate to the gastroenterologist with diarrhea, hepatosplenomegaly. Unlike Gaucher disease, where liver dysfunction or an abnormal liver function test is quite rare, these patients will often have some degree of abnormalities on the liver function test, and then have features that are similar to Gaucher disease. Now, I must say, I think with the experience that we have now in the lysosomal storage disorders, I think there's only one instance where a clinician requested Niemann-Pick AB and it turned out to be Niemann-Pick AB. Most of these patients we diagnose when the clinician requests Gaucher. We also test for Niemann-Pick AB at the same time. So it doesn't really matter, as long as you can just recognize this phenotype of hepatosplenomegaly, cytopenias, and then also some of the other features, the neurological disease, the macular cherry red spots, the abnormal lipogram, the bone pain, and so on. So if you recognize that and you request Cachet, we will also do Niemann-Pick AB. Okay, so we've mentioned quite a few of these. How they differ from Gaucher is the abnormal lipogram. We diagnose them by measuring the enzyme activity, and lysosphingomyelin is now available, not in South Africa just yet, but we are working on this, that we can use for monitoring and potentially also in future for diagnosis. Then there is a treatment for this, an enzyme replacement therapy, olipudase alpha, and there is one patient, to the best of my knowledge, and there may be more, but I think, as far as I know, there's only one in South Africa that is on treatment that is doing fantastically well. So again, we need to diagnose more of these patients because if we've got larger cohorts, then typically treatment becomes more available. So I'd like to show you this case study. This is a 7-year-old girl that presented with abdominal distension, which was present since 1 year of age. She has severe hepatosplenomegaly. A liver biopsy in 2014 in Zimbabwe was suggestive of a glycogen storage disease. Cachet disease or congenital hepatic fibrosis was also queried. She has no features of chronic liver disease, not jaundice, but the bilirubin is 54. She has a slight increase in transaminases. Only other feature is severe stunting. So I remember that we had a presentation some time ago from a histopathologist that showed us very nicely the differences between Gaucher disease and Niemann-Pick AB. So I think the accuracy of the histology is certainly to some dependent on who is interpreting it. But basically what I just want to say is that, if you do have features of Gaucher disease on liver biopsy, then certainly also consider Niemann-Pick AB. And if you just send the enzyme analysis, we will take care of the Niemann-Pick cases as well. So this is the enzyme analysis of the patient. Cachet, of course, normal, but then the sphingomyelinase deficiencies or enzyme activity is severely deficient. So we were able to make a preliminary diagnosis of Niemann-Pick AB. And then when you look at the genetics, you can see that it's quite a complex situation. So one of the variants was classified as pathogenic, not because any previous patients have been described, but purely based on the prediction scores from the ACMG criteria, and the other one was of uncertain significance. So, as far as possible, I think while we're still uncovering all the genetic variants, one certainly needs either an enzymatic or metabolic approach in addition to the genetic testing. I think this would probably have been a bit of a conundrum if it was only genetic testing that was done. Okay, so now moving on to Pneumonic C, disease that is not at this stage completely understood, but what we do know is that there's an impairment of lysosomal cholesterol trafficking, but the situation is different in the central nervous system where you find accumulation of GM2 and GM3. Also autosomal recessive, like most of the lysosomal storage disorders, and 95% of cases will be due to a pathogenic variant in the the NPC1 gene. This disease has got extreme heterogeneity. It can present anywhere from perinatal to the 6th decade. Not that different from Gaucher disease, where similar presentations have been described. And it's got visceral and neurological manifestations that are independent of each other. But an important point is that if systemic disease is present, it will always precede the neurological manifestation. So there's an opportunity there to make the diagnosis before the abnormal neurology sets in. Unfortunately, there are some patients, or maybe fortunately, that only has neurological disease. And there are two reasons why this disease is of particular importance to us. Maybe there are three. The one is that we are aware of some patients in South Africa with Pneumonic C. The second is that in the next 2 to 3 years, we will have a metabolic test to screen for this disease. And then there are various ongoing clinical trials. So there may be an opportunity to get some of our patients onto some of these clinical trials at this stage if we can make the diagnosis at an early enough stage. So this slide just illustrates the presentation. So many of these patients have got neonatal cholestasis, and depending on the severity, this may then result in neonatal death, but often it resolves, and then hepatosplenomegaly starts to set in. So if you have a patient with hepatosplenomegaly and you can get this early history of cholestasis during the neonatal period, then that would be extremely valuable to make the diagnosis. Currently, we are severely limited in making the diagnosis. Classically, you do this with Philippine staining, which at this stage isn't available in South Africa. There are metabolic tests, which we would like to set up. But at this stage, we're left basically just with genetic testing. And this is a complex gene to analyze using genetics. So quite a few patients have remained unresolved. There is, of course, also the neurological presentation, which is quite important. Vertical supranuclear gaze palsy is very typical of these patients. And so just to highlight again that, many IEMs are multisystemic, and it's important to look beyond the gastrointestinal presentation. Okay, so moving on to lysosomal acid lipase deficiency. This is a lysosomal disorder of cholesterol and triglyceride accumulation. And just because that acid lipase is deficient, so the esterified cholesterol and triglycerides cannot be hydrolyzed, and this then leads to the clinical phenotype. Again, autosomal recessive due to mutations in the lipid gene. And there are two clinical presentations, either as an early onset known as Volman's disease or a late onset known as cholesterol ester storage disease. I'm just checking my time to make sure we want to get through everything here. Currently, the diagnosis is genetic, but we may soon have a metabolic test available for this. So again, if you diagnose such a patient, please let me know. And then there are some treatment options for these patients. We don't have any patients on ERT at the moment, but like I say, we don't really diagnose it either. I definitely like to diagnose more of these patients. So just the differences in the clinical presentation. So Volman's disease, typically within the first year, often fatal, starts off fairly non-specific, vomiting and diarrhea again, steatorrhea, growth failure, hepatosplenomegaly, and then eventually liver failure. Whereas the cholesterol ester storage disease, this may start as early as early childhood, and they present with a fatty liver with a mild increase in AST and ALT, and then fibrosis progressing to cirrhosis. And they've also got then abnormalities on the lipogram. So yeah, important thing is here is just the presence of hepatosplenomegaly, early onset, and then later onset. The fatty liver. So it's easy to see how these patients can be confused with, for example, something like NASH due to obesity or diabetes. I'm not all that familiar with all the causes of NASH anymore, but it's certainly something to keep in the differential diagnosis. Okay, so those were the Swinkle I now want to move on to the Mikobolysaccharidosis. Now, the classic presentation of these patients will not end up with the gastroenterologist. So these patients are much more likely to present with the rheumatologist or the neurologist. But there's a reason why I would like to show this to you, and that is just because we do have these attenuated cases, and in these cases, hepatosplenomegaly may be a very important clue to the diagnosis. So most of the time, these patients have got dysmorphology. They may have neurological features, but they do have hepatosplenomegaly as well. And then the other thing that I think may be important to the gastroenterologist is the presence of hernia, which may help to make the diagnosis. So this we've got fairly well worked out. The important thing here is that it's those conditions that has Dermatin sulfate that accumulates, DS, that may present with hepatosplenomegaly. So this includes MPS 1, Hurler-Scheie, MPS 2, Hunter syndrome, then also MPS 6, Marito-Lamy, and MPS 7, which is extremely rare. We haven't seen any patients like this. So we have seen all of these except for MPS 7 and MPS 9. And they are, as you will see just now, they're quite common in South Africa and in Africa as well. Just some of the characteristic features of dysostosis multiplex, which refers to a number of orthopedic or bone abnormalities. And I'm going to show you some of these just quickly, just for interest's sake. So here is a case of the flattened vertebrals and anterior beaking. I don't really see, I'm not a radiologist. One can get the idea that they're flattened, but there's certainly beaking going on here. Here is the oar-shaped ribs that you can see in comparison to the normal. Sorry, the right-hand side is always the normal. Here I've got the bullet-shaped phalanges. I don't know if I would have spotted that if I had to look at an X-ray. Here's example of the dysplastic femoral heads. That is quite clear. Comparison to the normal. The thickened calvarium and the enlarged sala turcica. But this is really the slide that I want to get to. So this patient here in A is the classic presentation of a Mikobolysaccharidosis, and you can see the coarse facial features, the stunting. You can't see that much of some of the other skeletal features here, but certainly this facial presentation will alert you to the fact that it could be a Mikobolysaccharidosis. But you see some other patients here with very attenuated dysmorphological features. So for example, this patient here, this one here, and even this one here, although one can certainly see some dysmorphology in the legs. But it becomes clear that some of these attenuated cases should or could potentially end up with the gastroenterologist. Now, we don't see these patients, the attenuated patients in South Africa. We only see the classic ones, which is, it becomes very unlikely that we don't have attenuated cases. And so there's certainly something that I'd like you to be aware of. Then moving on to So what I want to just show you is that we started to screen for these disorders in around about 2017. Here I've presented our statistics from 2019 to 2022 because at that stage the program was well established. And what I just want to show you is that we have detected 25 patients with MPS 2 in 4 years, which makes it now the disease that we diagnose the most commonly in our laboratory. Now, it's not the most common metabolic disease. It's just because of very aggressive marketing and education and training from pharmaceutical companies, but it's certainly very prevalent. We've detected 21 cases of Cachet and 7 cases of Niemann-Pick AB. So around about 1 in every 4 to 1 in every 5 suspected Cachet patients will turn out to have Niemann-Pick AB. And you can see that around about 1 in every 20 requests that we receive will turn out to have one of these lysosomal storage disorders listed here above. Now, it's not all of them, but these are ones that present quite frequently and for which, not all of them again, but for some of them, treatment is available. So I just wanted to make you aware of the fact that these diseases are common, and particularly in Africa as well. If you go into the literature, Gaucher disease And the Mikobolysaccharidosis are common, and you should certainly test for them if you are confronted with a patient with a suspected storage disease. Now, here's the thing. I don't know if this is worrying or not, but this just gives you a breakdown of which clinicians are referring patients to us for lysosomal enzyme analysis. And maybe it's important, maybe it isn't. It's perhaps a bit small to see, but most is just general pediatricians, then neurologists, then specialist physicians. Then the pediatric neurologist sends about 4% of the samples that we receive, whereas the pediatric gastroenterologists only send about 2%. So my feeling is that we should be receiving more samples from the pediatric gastroenterologists. This test is available in South Africa free of charge, whether you in the public sector or the private sector, doesn't matter. It's free of charge. You just need to send the sample to us. If you are from Africa, just contact the lab. We're going to make a plan for you. There are some projects going on, but we will get your patient tested if you suspect a lysosomal storage disease. And you can send these samples through any of the pathology labs. So this is what we test for. In South Africa, we test for Gaucher, Niemann-Pick, Pompe, Fabry, and then Krabbe disease, as well as MPS 1. And then MPS 2, 3B, 4A, 6, and 7 we refer. Very important, if we receive the sample, we do the 6-plex. It doesn't actually happen exactly like this, but this is just for illustration purposes. In fact, everything happens quite simultaneously, but we'll do the 6-plex. If it's positive, we send for genetics. If it's Fabry, we will do GL3 for monitoring, Gaucher, GL1. MPS 1, we will do urinary gags for monitoring. Now, what's important is if it is negative, then we look at what was requested from the clinician. So if it was Fabry in a female, then it's important to do GL3 because the enzyme analysis may miss some of them. Important for you, if MPS was requested, we will send the sample for expanded MPS and we will suggest urinary gags and oligosaccharides. And if Gaucher was requested, we will send it for GL1. If you tick everything or nothing, you only get the 6-plex. No matter how important you are, you will only get the 6-plex. And this is just because the test is free of charge, but if we abuse it, then perhaps in future it's not going to be free. So in consultation with the pharmaceutical company that sponsors the test, this is the workflow that we've done. So please select the appropriate test and please provide us with some clinical information as well. So if you provide me with clinical information, you selected Gaucher, but the clinical information seems very suspected of an MPS, I'd still refer that as well. It's just cases where nothing that is ticked or where everything is ticked that is a bit frustrating. Okay, I'm going to run through some of these things. These are just things that I wanted to touch base on, but they are really presentations in their own right. So this is the peroxisomal disorders. These patients will present with mild cholestasis, but typically not through the gastroenterologist. Dysmorphology and the neurological signs are just more prominent. So normally they would come in through the pediatricians or the pediatric neurologist. The disorders of bile acids do come in through the pediatric neurologist, but at this stage, we are not that good at diagnosing these disorders. What I'd like to point out is that these patients have got a low gamma GT cholestasis. Not all the synthesis and transport disorders have this, but certainly if you see this, if you do have a patient with cholestasis with a low gamma GT, then that certainly is an alarm for a possible bile acid synthesis disorder. Currently, we don't analyze bile acids, but I also hope that that's something that we can change in the near future. And then just in terms of the cholesterol synthesis disorders, Smith-Lemli-Opitz syndrome and mevalonic aciduria and important disorders there. Again, very prominent neurological and dysmorphological signs. So typically they do not come in through the gastroenterologist, but perhaps something to keep in the differential. And then there are a number of other conditions that we will also just going to touch base on. So the congenital disorders of glycosylation, I'll show you where they are important. Currently, we refer this test. We don't do it in-house anymore. It has quite a long turnaround time, I must say, but we have quite a reasonable cohort of CGG patients in South Africa, so it remains important. Mitochondrial disorders, Marley have discussed, and then there are some others here that we typically don't test for that you must keep in mind. So what I want to get through before I run out of time here is we want to get to a simplified way in which a clinician can address the possibility of a metabolic disease. And this is what we approach. So we have an approach like this for gastroenterology. We've got one for neurology and so on. And it's not perfect, but I think it makes it manageable, and we're going to have the right information when we receive the samples, which is going to facilitate the diagnosis. So if you do have a patient, of course, if you've got a strong clinical suspicion, you think it's Cachet, it typically fits that, then only send the 6-plex LSD test, and we're going to make the diagnosis on that. But if the patient is more complex, then this is what I would suggest. So there's some basic laboratory tests that you need to do, which is listed here: UNE, blood gas, ammonia. Ammonia, we really need to have a result within 15 minutes, otherwise it becomes a bit useless. Glucose, and if the glucose is low, insulin, C-peptide, and ketones, lactate, pyruvate, liver function, clotting profile, homocysteine, important. It's not a serum homocysteine, apologies, it's a plasma homocysteine. You get this from pathology, not from us. CK, lipogram, uric acid, and then really just vitamin D and K is usually sufficient. So it's quite a large profile, but I don't think it's that large if you consider the cost of a day in ICU. And then this is what I would suggest as the basic metabolic test that you should order. And this is a serum and urine for amino acids, serum for acylcarnitines, urine for organic acids plus succinyl acetone, and then a dry blood spot for galactose-1 phosphate or GALT. If you just request a newborn screen, you're going to get both of these. As from next year, you won't be able to request a newborn screen at any age anymore, but currently you can still go that route, and that's quite useful. So you can replace 4-year with a newborn screen. That's going to give you the things, the enzyme and the metabolite necessary to make a diagnosis of galactosemia. So the advantage of this is that we cover a large number of metabolic diseases. So here I've listed the diseases where the basic metabolic test is very useful, where we are very likely to make a diagnosis. And then also those where the basic metabolic test plus the basic laboratory test is often preliminary. So we can't make the diagnosis, but it can certainly be helpful and can exclude a number of things. So this includes the glycogen storage diseases and the disorders of gluconeogenesis, Fanconi-Bickel syndrome, the mitochondrial diseases, which remain problematic, but all of this can limit it down quite substantially. The disorders of bilirubin metabolism, which you should be able to spot from the liver function tests, and then also the disorders of lipoprotein metabolism, which you should be able to spot from the basic laboratory test. So if you do this as your first workup for a patient with hepatic presentation with a suspected IM, you're going to exclude or diagnose or exclude a large number of metabolic diseases, and importantly, a large number of the severe diseases and those that kill patients that do have a potential treatment is also included here. So this will cover quite a number of diseases. Then if all of this comes back negative and we are pretty sure that we're not in this category over here, then there are some things that remain. At this stage, it's important to consider the things that we don't test for at the metabolic laboratory. This is tested for by the PAFs. So porphyrin studies, iron studies, alpha-1 antitrypsin, copper and ceruloplasmin, cystic fibrosis, and then also lipogram for tangy and beta-lipoproteinemia. So this you have to keep in the back of your mind. And then there are actually only a few metabolic diseases that then remain after you've done that initial workup. And what we propose is that we then classify them into either the those that has got storage, where it's mostly hepatosplenomegaly, but there may be other features as well, but hepatosplenomegaly should be prominent, mostly cholestatic, and then those that are mostly hepatic. And so if you have a patient that's got hepatosplenomegaly, you need to do the 6-plex LSD, the urinary gags, and the urinary oligosaccharides, and in future the lysolipids, which we don't have just now. Now, there are other conditions that can also cause hepatosplenomegaly, like, for example, mevalonate kinase deficiency, but we've excluded that with that initial metabolic workup. So these are the only tests that you need to do once you've done that and you still think that it's a storage disease. Okay, there are some clinical features that may, of course, be helpful. Then if you think that it's a cholestatic disease, very long-chain fatty acids become important. Typically, there will be severe neurological features as well. And you should also consider CDG testing here. the CD genes, the congenital disorders of glycosylation genes are quite complex. There's a large number of pseudogenes, so metabolic testing remains very important for these patients. And then what we can't do at the moment, but what we would certainly like to do in future, is bile acids and sterols. And then here are the disorders that you would consider potentially, and then some of the other additional features. Surprisingly, there are not many metabolic diseases that remain for those that can present with an hepatic presentation. And with this, I mean hepatitis, liver failure, cirrhosis, etc. So diseases of the parenchyma cells. Those diseases that I've listed in the previous slide here becomes quite important now, because many of them can have a hepatic presentation. So you really need to consider those. You can also consider very long chain fatty acids and congenital disorders of glycosylation. But really, when we get to this point, we should have excluded most of the hepatic presentation. So you're only really left with the storage diseases and then those that presents with a cholestatic presentation. So that is it in a nutshell. I'm sorry I went through it quite quickly. I just wanted to make sure that we do get through everything, and I thank you for your attention, and I'd be more than happy to take questions.
Thank you so much, Chris. That was really excellent. I have heard many diseases of metabolism talks, and I can kind of remember what they said for about 5 minutes, and then I forget. But this was a really nice and clear overview of the complex molecules, and really gave us a good approach to how to start investigating for them. I think personally, I'm really interested in the Mikobolysaccharidosis C that we, as you say, we have been unable to test. And I think I'm guilty of children with transient neonatal cholestasis don't really get the full metabolic workup which they deserve. And hopefully in future that will include the Mikobolysaccharidosis C workup. So I'm going to ask if anyone's got any questions. I don't see any questions. Chris, do you have anything to add? I saw you unmuted or stopped your video.
No, excellent. Thank you.
Okay, nothing coming up. I think you obviously explained everything beautifully.
Yeah, so I mean, the important thing that I just want to highlight is, you know what, the thing is, we do these presentations, and then I know that people forget, and to be honest, I also forget, the number of diseases have become of such that, you just can't keep track of everything anymore. And this is why I would really like to propose this metabolic workup that I've shown you, and I'll share. Obviously, we'll share the slides as well. But I think that is that will give us it will cast the net wide in terms of diagnosing the patients, but also diagnosing the ones that we have treatment available. I wouldn't say that it's 100% the most cost-effective way in which one can do it, but when you compare it to the cost of ICU stay, I think it's actually pretty cost-effective. And then certainly what I would like to request is we would definitely like to diagnose more lysosomal patients, just because there's a lot of interest, because all of a sudden, people are realizing that these disorders are very common in Africa, and the possibility of bringing some clinical trials to South Africa is on the horizon, including gene therapy, which I think is the solution for our African patients. So I would really like to build up the cohorts of lysosomal storage diseases in the next 5 years. I see there's a question from Sarah.
Go for it, Sarah.
Hi, Prof. Hi, Tim. Thank you. I really do agree with Tim. It was an outstanding talk, and I apologize if you've said or you've addressed the 2 questions that I have. The one is with the lysosomal storage card. I just remember someone saying to me, you can't test for all of them at the same time. Is that true, or can you tick, all of your 6 lysosomal storage disorders on that card? Or do you have to be guided by a strong clinical suspicion? That's my first question. And then the second one, for the Mikobolysaccharidosis, are we testing then a urine or serum? And should we be doing that on all our kind of neonatal hepatitides or hepatosplenomegaly, or again guided by the typical just morphology and more.
Sorry, Siri, you broke up there.
So I just wanted to know, with the Mikobolysaccharidosis, do we test all our hepatosplenomegaly? Would you advise that, or would you be guided more by a clinical suspicion? Because I must say, in a lot of the neonates that we do these workups on, we kind of mucopolysaccharidosis is not often high on our list of differential. And I don't know if you see the dysmorphology so early.
Yeah, no, but there are some of the, particularly actually MPS 7 is the one that you can see at birth. But no, the dysmorphology develop over time. So in a neonate with hepatosplenomegaly, it's somewhat unlikely. Just to answer your first question, if you request the 6-plex LSD, you automatically get all of the enzymes. So it's all done in one run: Cachet disease, Niemann-Pick, Pompe, Fabry, MPS 1, and Krabbe. It's all in one run. Why it is important to select a particular disease based on your clinical suspicion is that determines what we do further. So if you think that it is a mucopolysaccharidosis, you have to tick that, because if the 6-plex LSD is negative and you've requested MPS, only then will we send it away for the expanded MPS testing, which includes 2, 3B, 4A, 6, and 7. If you didn't request MPS, we will not send it. Similar scenario, for example, with Fabry, which is not important here. If you request Fabry and it's a female patient, it automatically gets sent for GL3. But if you request nothing or everything, then you don't get that GL3. So the clinical information that is provided is extremely important. But the enzyme, all of the enzymes are tested for simultaneously. In future, we can even include more enzymes onto the same profile. But the thing that worries me is we need particular substrates that we purchase as standards to run these assays. Now, for the 6-plex, it's easy because we get this in a kit. We don't actually use the kit method, but we do use the substrates. And I'm pretty sure that we will have continuation of that. But once you start to add things, then you become less certain about continuation of services. And this is why I'm very interested in testing the metabolites as an alternative to the enzyme analysis. I just think that that's a better way to go. Also, the enzymes are not stable, and so in the harsh African conditions, you may run into some problems. So I think all in all, metabolites may be better. With regards to the MPS disorders, so yeah, actually demonstrates, so urinary glycosaminoglycans is very, very effective in making the diagnosis. At the moment, we don't test for keratin sulfate. We will have that as part of the panel within the next few months, but at the moment, we don't test for that. So urinary gags is very sufficient in making the diagnosis. But typically, if you do suspect this, then I'd advise that you request the enzyme analysis as well as the urinary glycosaminoglycans, because even though the gags are sensitive, it cannot always distinguish the different conditions from each other. So you can see MPS 1 and MPS 2, you can't distinguish from each other, as well as actually MPS 7. Chondroitin sulfate is somewhat of a non-specific thing, so I wouldn't include that in my consideration. So it is going to be most beneficial to do both, even though the enzyme analysis are not going to give you all of these diseases. But it is helpful. So, we've diagnosed cases where heparin sulfate is increased, so you suspect Sanfilippo, and the enzyme analysis, which is for 3B, is negative, then okay, it's most likely 3A, because 3C and 3D is very, very rare, and that can give you some guidance on where to go next. So if you have a patient where you suspect a mucopolysaccharidosis, my advice would be to do the 6-plex LSD, the urinary gags, and also the urinary oligosaccharides. And that's just because that some of the mucolipidoses will have mild to moderate increases in both oligosaccharides and glycosaminoglycans. Like I said, we're not that great at this stage in diagnosing those disorders, but that's what I would advise. I think I've answered all of it. But you're welcome to respond.
Yeah, thank you. Thank you. So the one thing I'll just, and maybe someone in the audience can comment also, is you wouldn't be doing testing for MPS in your typical neonate that's presenting with a, cholestatic picture and a hepatosplenomegaly. I mean, that in itself is not enough to suspect, in my mind, a mucopolysaccharidosis. I suppose I'm just asking because it's never kind of come across. I've never come across it in a differential for me, especially in a neonatal cholestatic.
I agree.
Else.
Yeah, I agree, with the exception of MPS 7, which could be present at birth. But no, I mean, if you have a patient in the neonatal period with hepatosplenomegaly, I do think that Cachet and Niemann-Pick AB should be on your differential, but the MPS I'd move to the background a little bit.
Okay, no, all right, perfect. Thank you. That's thanks a lot.
Pleasure.
Tim,
Thank you
Chris,
so
thank
much,
you
Prof.
very much. Tim,
Sorry.
if I could just say, I mean, Chris, the point about these sessions and this platform is really, as you've said, to cast the net wide and obviously to educate ourselves. But at least now, this is important. You've given us an indication of where to refer and also when to refer when we have, these very rare kind of disorders that we're concerned about. We also have a very strong presence in Sub-Saharan Africa, and we'd be very, very delighted to help you, collate any drug trials or any presence in Sub-Saharan Africa.
Yeah, like I say, I mean, if there are clinicians from Africa that want to do testing, particularly the testing on dried blood spots, there are 2 projects running in Africa at the moment. So there's a way in which we can still get it done for free. And otherwise, there are also other ways in which you can do it. So just contact us and we're going to see if we can make a plan for you.
Thanks, everyone. Thank you again, Chris. That really was an excellent presentation. I also just want to thank you for always being available to discuss these difficult patients. And I promise we're going to send you more LSDs. So we won't miss them anymore. I also want to thank the Echo New Mexico team and Echo India team providing the logistical support. Thank you to the Gastro Foundation, as always. The talk will be available on the Gastro Foundation website. Thank goodness, I'm going to watch it many times to remind myself. And thanks you to all the participants. Thank you for joining us. And next week, we'll move back to the adult gastros talking about HCC. Thank you very much.
Thank you.